We are your hosts, Nikki Shore and Jessie Swain, and you are listening to the American Journal of Infection Control podcast, Science into Practice, brought to you by the Association for Professionals in Infection Control and Epidemiology to highlight work published in our peer-reviewed journal, ACHG.
Join us as we speak to those in the field of infection prevention and control, like us, as well as other experts, to learn about some of the latest research in the field and how it can be put into practice. We hope you will listen in, learn something new, and apply this information to your work. If you are not a researcher already, we hope this podcast will get you thinking about areas where you can carry out your own research. Hey, Nikki, what's shaking?
Oh, hey, Jessie, just getting back into the swing of things and... just getting back into the swing of things after having been home with a newborn for quite some time. And, newborns can be pretty germy, right?
Yeah. Newborns, small children, pretty much until they're out of your house.
Okay, so people in general can be kind of germy. I do have a joke for you. Are you ready?
Mm-hmm.
Okay, why did the germs cross the microscope?
I don't know.
To get to the other slide.
I always thought of that, but I didn't want to give it.
You didn't want to give it away. That was so sweet of you.
I mean, as a past microbiologist.
That's true. Yeah. Well, it's good to hear your voice again.
You as well. So today we have with us Mrs. Yvette Williams to talk about reduction in patient refusal of CHG bathing.
Ooh.
So Mrs. Yvette Williams, BSN-RN, CMS-RN, was born and raised in Port-au-Prince, Haiti. She actually moved here with her family when she was 12 to Florida, and then graduated from Florida Gulf Coast University with a BS in education. Mrs. Williams was then a K-6 teacher for almost 8 years before going back to nursing school.
So she's used to the germy kids.
Exactly. Oh. She knows where we're coming from.
Yeah. She knows why the germ crossed the microscope. Okay, I'll shut up now.
Okay. So she went back to nursing school and actually graduated from Florida Southwestern College with an ASN degree in 2019. And then in May of 2023, she graduated from the University of North Carolina in Greensboro with a BSN degree. Well. And then... in August, received her CMS-RN certification, which, if you're unsure of what that stands for, is the Certified Medical Surgical Registered Nurse. So that's
cool.
Really cool.
Yeah.
In 2019, she actually began working on a general surgery unit at Duke Regional Hospital in Durham, North Carolina. And during that time, she joined the Clinical Practice and Nurse Practice Councils, where within a year, she actually became the co-chair of the Nurse Practice Council. And then within her first year of working at Duke Regional, she also applied for a year-long fellowship on the significance of CHG bathing for patients in non-critical areas. And at the end of that fellowship, Mrs. Williams submitted a group abstract that was accepted in the hospital's infection control department as well as ACHG.
Very cool. Very, very cool. We're glad to have her.
Yeah, exactly. So Nikki and I would love to welcome you to talk with us today, Mrs. Williams. Thanks so much for being here.
Absolutely. Jessie and Nikki, thank you very much for having me.
Mm-hmm. So can you just kick us off today by telling us what actually prompted this CHG patient refusal bathing study?
Yes, absolutely. So this project was pretty much a continuation of one that was birthed from a group of fellows from the university and the hospital as well. And then within the year that I started working there, which was actually around the beginning of 2020, I learned about a fellowship program that would last about a year. I applied, my supervisor at the unit then supported me, and then I joined in. Again, I was within my first year of working as a brand new nurse, so I had no idea what I was getting myself into, but I enjoy projects, and I wanted to kind of get going and hit the ground running with my nursing career. So I decided to apply for the fellowship and was accepted to be part of the team. So that the main group that started out with the CHG bathing actually took it off with the ICU areas first. And then as part of their dissemination process, the fellowship program I joined started out from there. So it was a year-long fellowship that was led by an interdisciplinary team, including bedside nurses like myself, the professors from the university, one of the nurse scientists from the hospital system. We all joined in together to do an evidence-based practice research project for CHG bathing in non-ICU areas, to, again, continue on with having it being done in the ICU areas already. So for a year, the group of us, we investigated the process of CHG bathing on each of our individual unit. And then we also analyzed the literature on CHG bathing. We conducted monthly meetings for discussions and having different speakers come on board, and also learning how to dissect literature, how to analyze it, to find what we were looking for to support the practice that we were doing on our units at the time. And then we, again, throughout those monthly meetings, we would come together and join forces pretty much with people from different disciplines to make sure that what was done in the ICU areas would also be done in the non-ICU areas as well. Because at that time I worked in a general surgery unit, and we would get patients with central lines, we would get patients with PICC lines, we would get patients with dialysis catheters. So we wanted to make sure that even though those patients were not in ICU areas, they were also receive the same type of care to help prevent CLABSI among that population as well.
And I think it's really cool that you jumped right in to do this, and it's such an important intervention for our patients. So it's a great project to start your nursing career with. And being a project lover myself, and I have my CPHQ, so I had to study a lot about, the PDSA cycles and such. So I'm curious, over that course, what did the first PDSA cycle look like, and who led the project?
So the fellowship was a group of us. And then among that group were a small group of bedside nurses. The bedside nurses, what we did, we looked at our units and see, okay, how was CHG bathing being done? And where were the areas of improvement? So for example, I saw an area of improvement for education. I noticed there was a lack of education among the staff and also among the patients as to the reason we're doing CHG bathing and actually completing it all together. So each of the nurses in that fellowship program for the year, we discovered different aspects of CHG bathing within our unit, and we also saw the areas where we needed to improve. So again, myself, I focused on patient refusal and also the lack of education. Another nurse focused on documentation. Another nurse focused on the task list for for CHG bathing. So for example, at first, it was always, by 6 p.m. on my unit. So that particular nurse who did, hey, how about we put it at 2 different times? That way, either night shift or day shift will get an opportunity to get it done, and that would increase the likelihood of actually completing the bath. So that was her focus. Again, my focus was on patient refusal and also educating my staff, whom would then educate the patients. So my aim was to educate the staff, educate the patients, which would then lead to decreasing the amount of refusals. In regards to the cycles, the first cycle, I wanted to remind the staff about completing the CHG baths for our patients. And I also wanted them to be aware, like if you have a patient with a central line, if you have a patient with a PICC line or dialysis catheters or what have you, or even patients with Foley catheters, we target those as well. So for that first PDSA cycle, I posted CHG educational flyers, and the frequently visited places around the unit. So, the medication cabinet area, the nurse's station. And believe it or not, I even posted them in the bathroom.
Yep.
Because it is a frequently visited area. And as nurses, as much as we like to, bypass using the restroom, we do make it there from time to time.
Well, that's interesting. Can you tell us what you found after the first cycle and whether or not you made any significant changes in cycle 2?
Yes. So first cycle was posting those flyers in frequently visited places where I wanted the staff who have been there for a few months, a few years, or much longer than that to begin asking questions. based on those questions and comments, then that kind of led to what I would include in PDSA Cycle 2, which consisted of personal educational sessions, where there was one-on-one with the staff on the unit, or it was during shift changes, which like ideal time to kind of get quick little bursts of information out to the staff. And also during monthly staff meetings, I would get a minute or two to kind of just, plug in a little bit of information about CHG baiting there as well. And then, also e-learning modules. So the whole health system have, this LMS system that we use that has modules on just about anything that we do. So I found the one for CHG baiting. I went ahead and sent it to the staff and have them take it. And at the end of that module was also a competency test that could allow them to kind of see how they did with gaining the information and answering questions about what they've just learned as well. So with all of those things being done, then after that, I send out a short quiz to kind of get a little bit of an assessment to see where they are and what holes do I need to fill in and what information do I need to re-educate on and things like that.
It sounds like a tremendous amount of work, and also a lot of different areas that were, provided this information. And based on reading the article, it sounds like there's some really creative thinkers in this group of nurses as the cycles went on. Can you tell us a little bit about the development of the badge buddy?
Yes, absolutely. So if you know nurses, we like to attach little things to our badge that we find helpful that we can just flip and then get the information that we need in a quick manner. So this was actually one of my favorite parts of the project because it allowed me to bring in another team member from a different department. So I actually worked with the communications manager for the hospital to work on this badge buddy. So I reached out to her. I said, hey, this is the idea. This is what I would like to do. How can I go about doing it? So she was able to help me through the process and also getting the actual card done, what information I want to put in it, the direction I want the information to be in to make it easier when the nurse flip her badge or the nursing assistant flips her badge, be able to quickly read the information on the go. So that was a really cool part about bringing her in and bringing another team member to join in. So once I kind of give her the vision, she pretty much worked her magic. We exchanged a few emails, and then next thing I know, the badge were ready to be printed. And when that little box full of badges come on the unit, I was excited like a kid on Christmas Day. They came out beautifully done and printed, and they served the purpose that I had in mind, which was providing quick and on-the-go education for the staff on the unit.
And you know what Nikki and I always say, 2 heads are better than 1. So creative thinking with your nursing colleagues there.
Yes. And like I said before, this was a group project. It was quite the collaboration. We had people from just about every department within the health system come in to join. So
cool. So what other significant changes to the PDSA cycles happened moving forward based on what you saw from previous cycles?
Yeah. So taking from one cycle to the next, saying, okay, what do I need to carry on? What do I need to change? Where do I see room for improvement? One of the main changes throughout was disseminating the educational information in ways that would target everyone's learning styles. So for example, if I notice, hey, the flyers work for some people, but not for others, then I focus a little bit more on shift changes, doing a quick little burst of session or information there. If, some people will get it from there. Others, it was the learning module that was a little bit more, beneficial to them. For other people, even then, it was just actually, hey, I'll bring in the wipes. These are the wipes that we're using. This is how we're using it. This is the time that we're gonna, plan with patient to do the bats and those kind of things. So it was just a matter of figuring out, okay, how do different people within the unit learn, and how can I bring the information to them in a way that makes sense? So hopefully within each ways of giving the information throughout the PDSA cycles, each group of people's learning styles were able to be met. And then finally with the badge buddy, hopefully the rest of the staff caught on to that as well, having something they can hold, something that they can put on their person just to say, okay, this is where I can get the information that I need.
That's so thoughtful.
It is. Yeah. We, as a former bedside nurse, I always love resources like that. They're very, very helpful.
Yes.
And Now, when you reviewed the data that was collected over the time, did you see any significant changes in regards to patient refusal?
Yeah. So when I started, I wasn't sure, you never know how things will turn out and what kind of changes you would see. And you hope for the best. We all want 100% compliance when it comes to caring for our patients. We want, 0% refusals on the care that we're providing and those kind of things. But based on those PDSA cycles and results that we look at, there was a reduction in the median percentage of patient refusals that were documented from 23% to about 8% after the PDSA cycles. And also, as far as compliant with documentation with the CHG baiting, we saw a slight increase from 46 to 47%. So in general, when we look at everything in the time frame, CHG completion increased from 77.9% the year before to about 85.7% from July 2022 to about December 2022 when we pulled that report.
Nice, very nice. And it was noted that one of the secondary aims of the process improvement project was to assess nursing knowledge of CHG bathing. So how did you assess that initially and then after the project?
Yes. So initially, I mentioned a little earlier that the staff received a short quiz. So we had the e-learning module that came with a short quiz on its own to assess competency. And then I also sent out a short survey quiz as well to assess knowledge initially. And then the results of the quiz kind of helped guide the PDSA cycles that came after, and as well as the type of information I would provide during the shift changes and during the monthly staff meetings as well. So to further educate the staff, PDSA Cycles 2 included a learning module and also other types of short little videos that I sent on how to use the wipes and those kind of things as well. And then after PDSA Cycle 3, that quiz that I sent at the beginning was sent again as a post survey to kind of see what knowledge has been gained and the increase from the first survey to the second one. And then the time in between where small informational sessions were being done and educational materials were provided to the staff as well.
Mm-hmm. Mm-hmm. Did you see an improvement?
I did see an improvement, slight as it may have been. And as you know, getting the buy-in at the staff was also one of the barriers that I had to work against. But as much as I could get, the response that I got back did allow me to see some improvement.
Do you think it was the badge buddies, or what do you attribute to the improvement?
I think it was a combination of things. Like I mentioned, as a former teacher, approaching people from, okay, what learning style works best for you? How do you best receive information? If you have to do something, do you want to see it done first, or would you like to walk through it as you do it, you hearing the instructions being given? So I think it was a combination of things. And I would also say definitely targeting different learning styles, giving the information in different formats, I think also helped.
So another secondary aim that you talked about in the article were to observe the number of CLABSIs before and after the project. Did you happen to see an improvement in the CLABSI rate at all as a part of this improvement project?
I did. Also a small one, but I did see one. The unit I worked on, we didn't really have a lot of CLABSIs to begin with, one here and there, honestly. So we saw about a 6% decrease in the CLABSI rate, and the unit has had 0 CLABSIs from July 2022 to about May 2023, I believe. So that wasn't too much of a big focus, decreasing the rate of CLABSIs, because we didn't have a high rate of that to begin with.
Well, any improvement is an improvement, right? So we're happy in infection prevention whenever we see any improvements in our hospital-acquired infections. So bravo either way. What do you think could potentially have been the biggest factor to the improvement in the refusal rate from patients?
I truly believe the biggest factor was the education piece, which is why I decided to focus on that and zoom in on it a little bit more, because I realized if the staff needed to be educated a little bit more or reminded, refresh memory on those in that particular process, which would then lead to the staff educating the patients. So one day I just kind of went around the unit and looked at the patients who had central lines or what have you that day. And I went around just to do a quick little poll, and I asked, have you had your CHG BAT done today, after introducing myself and all? And I've had a lot, for those patients, I don't remember how many that day in particular, but I had quite a few no's, and try to figure out why the answer was no, I haven't had my bath, or no, I've refused a bath today, or I've refused a bath. When I try to kind of dig down a little bit more to see the reason behind the no, it was mostly because I wasn't sure what it was, or I haven't learned why I'm getting the bath. So it took a little bit of time there to educate the patients on, okay, this is why we're doing the bath. That's the reason behind it. And the big picture is that we're trying to decrease the risk of getting an infection and those kind of things. So through these short little verbal surveys of the patients, I learned that they were not aware of the significance of CHG bathing. So they respectfully declined when they were asked. And also, patients would get a bath once and dislike the feel of the CHG on the skin immediately after the bath. And that piece I noticed also required education. Like, hey, after a few seconds, a few minutes, it'd dry off and your skin will feel, as smooth as it was before. And there'd be no major changes on the texture of your skin just because of the bath. It just needs to dry up first. And that kind of opened the door for me to educate a little bit more. And also another thing that made a big improvement, or a factor that partake in the improvement, is the fact that getting the bath done was placed at one particular time. Again, one of the other nurses in the group, her focus was on changing the documentation process. Let's put the bath at 6 a.m. and 6 p.m. So that way we know 2 different shifts will have an opportunity to get it done, because it needs to be done at least once a day.
I think, your comments just then really speak to something that we touch upon a lot, which is involvement of the patient and providing that education and taking the time to, allow the patient to understand what's happening as part of their care. And I think that would make sense to me, because it does seem, or could seem particularly awkward to have this type of bathing happen. And if I were a patient and didn't understand, I feel like I might also say, no, thank you. But having understood, the purpose behind it, might be more willing to then say, oh, yes, of course. So I think that definitely speaks to us bringing the patient along with that education and being part of the process.
Yeah, especially if you've got a central line or anything that leaves you at high risk for infection. When you find out what that's for, I mean, I think you would be highly likely to take the CHG bath.
Yeah, absolutely. I mean, that's for all of us in pretty much everything. If you want somebody's cooperation on doing something, it's best to educate them. Personally, I like to know what I'm doing, when, where, how, before I kind of get myself involved. And my husband kind of, he's a little bit different than that. So when I ask, okay, where are we going? What time we're getting there? It's hard for him to surprise me, because I want to know all the details before we get there. So I kind of take that on my unit, and I don't want my patients to be surprised with the bath they don't know anything about, or a bath that they're going to say no to, because that's a very, it's a very personal thing. So we have to be mindful.
It almost sounds like you've taught children before.
It does. Yeah, so we have to bring them in. We have to partner with them and provide care in a way that can involve them as well.
So, bringing that up, after you educate the patient, I really liked this idea of the patient refusal escalation pathway. So can you describe how that might be implemented in that case, after you do educate the patient and they are still refusing, I guess? Is that the...
Yes,
is that it? Okay.
That's the idea behind the escalation pathway. So simply put, it exists to further educate and encourage patients to accept the bath. For example, if the CNA goes in the room and making plans with the patient for the day to do the CHG bath, and the patients refuse, then the CNA would go next to the nurse and said, hey, I went to the room to talk to the patient, to discuss a plan for the rest of the day, a good time that works for the patient to do the bath. However, they've refused. That nurse will then go in the room, pretty much do that process again, and talk to the patient, ask to find out the reason behind the refusal. And then once that reason is figured out, either the patient will change their course and said, oh, okay, I'll let's do the bath at 4 p.m., after lunch or something like that. If the patient refuses, then that nurse has 2 options. We can bring the charge nurse in, We can also contact the provider and have, hey, would you mind coming to bedside with me and let's educate the patient together and see if we can work something out to where they would agree to take the bath, as long as there is, no reason like allergy or something like that as to why they're refusing the bath. But honestly, in my experience, I've gone in rooms and I didn't have to, bring the charge nurse in or bring the provider in, because usually what I found out, for the most part, once I go in that room and having been heard from the CNA that the patient refused, usually it's a matter of, I'm just not ready for it right now.
So, yeah, go ahead, because I'm curious too. I want to know if there is any data on the increased rate of patient acceptance after the education.
Yes, I'm trying to remember the article I read, and I don't have a specific number for you, but there is an increase after they've received education. And I think also that's one of those things where we can kind of bring a little bit of common sense in and say, hey, if somebody says no because they don't know, then once they are made aware, once they are informed, the likelihood of them saying yes should increase theoretically. Mm-hmm. Mm-hmm. And that's what I found out when I go in the room and re-educate the patients and try to get to the bottom of the reason they said no or the reason they refused. If it's a timing issue, like, I wasn't ready to do it now, then I could say, what's a good time for you? What's a time that would work? And then between the nursing assistant and the nurse, there should be a time that works for the patient and whoever's going to help complete that bath.
Yeah. And I'm wondering if there's any other factors that contributed to the success or could have been barriers to the success of the project.
I'll start with the barriers. That way I can kind of end on a good note with the success. The main barrier that I came across was the staff's buy-in. So just a matter of getting everyone on board, getting everybody to join in with that in the project, and just said, okay, let me put my hands on the plow. Let me put my hands on this pot as well to join in to make sure that this project is a success. And of course, whenever you're doing a group project like this, the staff that you're not necessarily getting buy-in from, their opinion matters as well. Their input also matters because there's a reason. And the reason could be, hey, that's another task on my task list. The reason could be, hey, there's just not enough, hours within my 12-hour shift to add another thing to my list, to add this, to add that. So then that's when we bring in, okay, we're all working together here. And usually during report, I build a habit of telling my nursing assistants, like, hey, between the two of us, let's work out a time that we can have this bath done for the patient. And then we'll bring the patient in. What time do you prefer? After breakfast, after lunch, before dinner, after dinner, right before bed? What's the time that would work for you? So then I realized, okay, what was the reason I got a little bit of resistance? Same thing I did with the patient. I'll re-educate again, try to get to the bottom of the reason for the refusal. Same thing with the staff, try to get to the bottom of the resistance that I may have felt there, and try to figure out ways to kind of like, okay, what if we put the task on the work list twice a day? That way one shift or the other would be able to have it done. And then find out whatever the other reason is that they may be a little bit resistant to the change.
I'm impressed with what appears to be so much time and energy and dedication that went into this project. Mm-hmm. It just sounds like, based on all of the different educational tools that were used and the different areas that you focused in, and then the various cycles of the PDSA that happened and then were analyzed, that it was just so much time and energy. What key points would you like to leave our listeners today about this project?
Absolutely. If you don't mind, I'll go back to the previous question a little bit and add in the success that's going to tie into the key points I would like to leave the listeners with. The success of that project really came together because of the team that worked together. Literally everyone was hands on deck, even if there were resistance here and there. But like I mentioned at the beginning, we had professors from the nursing department. We had a nurse scientist. We had bedside nurses. My supervisor and the manager and assistant manager on the unit were very much on board, assisting me every step of the way. There were no areas where I needed help with something or needed something done that either my manager or the assistant manager, like right on it, helping me. Again, I'm not very tech savvy, So putting the survey together to send out to the staff, the assistant manager was all in on that one to assist me. The communications manager coming in to assist with the badge body. So we had a group of people who were supporting the bedside nurses who were taking that project to their unit. So that really count in for the success of the project. And last but not least, the key point that I would like to leave the listeners with today is that it is easy to say no to something if you don't know anything about it. But I believe one of the best ways to involve patients in their care that we're providing is to educate them in order to get them involved.
Indeed. Yeah, this is a really cool project, and we're really stoked to have had you on, and very thankful that you agreed to come talk to us today.
AGIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology with input from the APIC Research Committee and Pat Stone and Jean Brandt at AGIC, and APIC staff Shanina Knighton, Chris Ruiz, Bobby Gulshan, Christine Miller, Kaylee Deaton, and Kelly Lynn Russell. We work in partnership with Human Factor and audio tech Blake Alton. To hear other AGIC podcast episodes and to access information about this podcast and the field of infection prevention and control, go to our website at agicscienceintopractice.org. That's AJIC scienceintopractice.org.